So it's got effects at 5-HT to 1A and B, which are the sort of ecstasy, euphoria type effects, reduction in anxiety and depression, feelings of love. That's really good. It's very important in psychotherapy to have that feeling. I had a patient turn to me on MDMA. She was very, very high. She turned to me on the bed and rolled up the eye shade. She went, "Ben, is this what love feels like?" And I stopped and I thought, well, this is a transient drug-induced experience. This is not the noble feeling of love. Love is far more of this. And then I stopped and I thought, well, hang on, like, she feels held, she feels contained, she feels warm, she feels safe, she feels empathic. And I went, yeah, this is what love feels like. And she went, oh my God, I thought so. I've never had this before. I've never felt love before. My whole life since I was born, I've only felt fear and pain and exclusion, and now I know what it feels like. And I've heard people say, I love you, and I've kind of said, oh, I love you back. But never meant it. Now I know. And she doesn't have to stay high. We talked about it the next day. She has now a platform on which what love feels like, and she can go on and use this. So that's 1A and 1B. There's a mild effect at the 2A receptors. Now, the 2A receptors is where the classic psychedelics work, but it's much more mild with MDMA. We're not talking melting walls and morphing faces or ego dissolution or anything like that. But it is enough to have this thinking outside the box and this originality of thinking. We've then got this paradoxical effect. The amphetamine part of the molecule causes a stimulation, and this is good. This engages the patient. It motivates them to take part in treatment. They feel an urgency to do it, like, let's do it. Let's do some psychotherapy. But at the same time, there's an alpha 1-2 relaxation effect, which takes the edge off that hypervigilance that typically comes with painful memory recall. So what you've got is speeding up and slow down at the same time. And if anybody here has taken, there's a drug called ecstasy. Some of you look quite groovy. You might have taken it. It does have this very weird experience of feeling speeded up and slowed down at the same time. And you're on the dance floor with the people who are only on the sedatives, and they're like this. And then you're on the dance floor with the people on the amphetamine and the cocaine, and they're like this. And then you're on the dance floor with the people on ecstasy, and they're a little bit of both. So you've got this. What that does from a pharmacological and psychotherapeutic point of view is it drops you into the optimal arousal zone for psychotherapy. Perfect place to be for trauma-focused psychotherapy. And finally, there's a hormonal effect with the secretion of oxytocin. As you know, oxytocin is secreted from the brains of breastfeeding mothers, which engenders a sense of connection and empathy and bonding. So, perfect tool. If you were going to invent a tool for trauma-focused psychotherapy, you'd come up with MDMA. Short-acting, it's like 6 to 8 hours max. Mildly perceptually disturbing, but not like classics. Almost always pleasurable. It's really important in a drug, really important. This is why I favour MDMA over classics. There are a few drugs in psychopharmacology that are so invariably pleasurable. I mean, opiates are another. I mean, when I'm teaching pharmacology to medical students, I say, if you don't like heroin, you don't have a brain. You seriously need to go and see a neurologist. There's something wrong with your wiring. You know, it's good that it's invariably pleasurable. Because you want it to be tolerated. Safe. Very safe. I've been talking about ecstasy MDMA for 20 years, and I used to put up graphs and figures of holes in brains and neurocognitive tests, and I just don't bother. The psychopharmacology community, which back in the early 90s when I started working with these compounds was split in a 50-50 sort of, is there neurotoxicity? Now it's like 99-1. 1%. There's one guy in the UK who's still banging on about MDMA neurotoxicity. We've had MDMA heavy ecstasy use throughout Europe for 40 years. Where's the depression? Where's the dementia? Did not happen. So very, very safe, especially in therapeutic applications. But it's this access to traumatic memories, it's this enhancement of empathy, and it's this inhibition of the fear response that makes it so powerful. So a very brief neurophysiology, neuroanatomy. The little swollen bit at the top of the spinal cord there, that's called the brainstem. Really basic bit of biology. Cockroaches have one of these. It measures blood, it regulates blood pressure, blood temperature, blood chemistry. Cockroaches have it, not particularly sophisticated. Go a little bit further up the evolutionary chain, we get the midbrain or the mammalian brain, and that bit in red is the amygdala, part of the limbic system. A bit more sophisticated. It allows you to respond with emotions to your environment. But it's what we call a bottom-up process. There's no cognitive part. It's like a knee-jerk reaction. So a guy comes running into the room now with a knife, your amygdala area in red will fire. Get ready. It triggers a hormonal response, fight, flight, freeze. You don't have to think about it. But fraction of a second later, prefrontal cortex, that yellow area, this is our uniquely, loftily human part of the brain where we have logic and reasoning and the ability to debate and judge and plan. And those two areas, the yellow and the red, are in constant communication. So the guy comes in with the knife, or it could be a female, and the amygdala says fight. The yellow goes, no, but she looks okay, she's kind of friendly, and it's not a very big knife, and you're feeling pretty good today, and she's wearing a chef's hat, and she's carrying a menu. It's probably okay. So you've got this constant debate. Now, if you have been exposed in your childhood to pain and trauma, if every time your caregiver comes into the room, you don't know if you're going to be kicked or punched, or they might sit down and do a jigsaw with you and play with you, but they might burn you with a cigarette or rape you. You learn to have a exaggerated amygdala response. This is a positive neuroadaptive response. Indeed, PTSD is the sign of a healthy brain. You're being attacked. You have developed a defense mechanism to prevent against attack. You are terrified of everything and everyone. Everyone is out to get you. And you have physical brain changes. The brain actually develops in terms of its networks and connectivity physically in infancy and the early years of childhood to protect you. So when you hear that key in the door and you're an 18-month-year-old on the floor, you don't stand up with open arms like this. You dive behind the sofa because you've seen it happen too many times. And the prefrontal cortex shrinks, it becomes attenuated. There's no point in seeing the good in things or the good in people. It's only going to get you hurt. And this is a physical brain change, and this has been demonstrated in fMRI scanning with abused, very young children. Now, MDMA does the exact opposite. And this is a study that we did with Robin and David at Imperial. It reverses that. It boosts the prefrontal cortex. It allows you to see things in a positive light, both yourself and others. It gives you empathy and pro-social feelings towards others. And it shrinks the amygdala. You're not scared of stuff. You're not scared of yourself. You're not scared of your memories. So, we add these things up. Positive mood, creative thinking, this stimulation, relaxation, empathy and bonding, and this brilliant phrase, it selectively inhibits the fear response, but leaves the other faculties intact, and that's really important. Because there's lots of drugs that inhibit the fear response. A bottle of vodka inhibits the fear response. Bag of heroin, great, that inhibits the fear response. But those are dirty drugs, you can't work on those. With MDMA, you can think, you can feel, you can talk, you can reflect, you can remember your childhood, you can get up and make a cup of tea, but your amygdala is turned off. It's the most extraordinary feeling. And I will share an anecdote with you, but just don't tell anyone. I can remember age 18 in 1990, at the end of a rave, sitting there with all my friends, and actually this was in that Netflix thing. Somebody said, oh man, it's so beautiful, also loved up. Someone said, let's imagine the worst thing in the world. And someone went, let's imagine our mums dying. And we all lay there and then went, it's not that bad. I didn't know anything about MDMA therapy, but that, now I realise, in a nutshell, is what we do in MDMA-assisted psychotherapy. The patient is in a position to go there towards their forbidden, avoidant memories. And this is why we have treatment resistance in all of these disorders. Because the overlying maintenance drugs don't work enough in enough people, and the psychotherapy you get so far, and then you hit a brick wall. Because you'll talk to that psychotherapist until you get to that conversation about that night when that thing happened, when my grandfather came into my bedroom when I was 10 years old. I'll talk about anything, but I won't talk about that. And on MDMA, it's like, I can. And it's amazing seeing the look on patients' faces when they say, I can tell you, he came in, he was wearing this, he came up to me, and the tears are streaming down their face. They are not in ecstasy. It's not ecstasy. It's still very difficult trauma-focused psychotherapy, but they can do it. And MDMA is like this bulletproof vest. It just gives you enough courage to go there and do the trauma-focused psychotherapy, which can move you from that 50% treatment response group, treatment resistance group, into the 50% treatment response group. So we set up the Bristol Imperial MDMA study. It had never been done before up till now. Up till then, all the work was with PTSD, but as an addiction psychiatrist, I've always thought of alcoholism as basically PTSD plus ethanol. So it was obvious to do. Open label safety tolerability study, no control group, no placebo. And I know you're thinking, that's not very methodologically sound, Dr. Sessa, but you have to do that. New drug in a new condition. You have to start with a safety and tolerability study. We have 14 patients recruited from local pre-detox alcohol groups. They had MDMA twice, alongside non-drug therapy sessions, 125 milligrams followed by half that dose after 2 hours, just to extend the session a little bit. And we used male-female co-therapy pair. That's what it looked like. So we did screening, consent and eligibility. They then underwent an alcohol detox, came down to 0. They then came into the 8-week course in which they take MDMA on 2 occasions, followed by next day integration sessions. Then we follow them up at 3, 6 and 9 months to collect outcome data. And that's a pretty typical protocol. Whether you're talking psilocybin, ketamine, DMT, LSD, all psychedelic protocols have this typical feature of drug and non-drug sessions, and that's essential. Just taking the drug alone at best isn't going to be very useful, and at worst could be harmful. You do most of the talk therapy work outside of the drug experience. Most of the talk therapy work is done to integrate and unpackage the material that came out in the drug experience. Although with MDMA, less so. Towards the end of the day, when they're a little less high, they do a lot of talking. Now, as I said, here's a small tip when writing PowerPoint presentations about psychedelics. Don't use the word risk. You can write exactly the same slide and say safety profile of MDMA rather than risk profile. Let's start getting people to realize that you can use the word safety, not risk, and say the same things. MDMA is incredibly safe. Incredibly safe. What is it? 750,000 doses of ecstasy are taken every weekend in the UK. 750,000 doses of ecstasy every weekend for the last 35 years. And yet rates of morbidity and mortality are staggeringly low. Staggeringly low. And I ask any psychiatrists in the room to tell me if they have their wards and clinics full of ecstasy users. They almost certainly have wards and clinics full of people who've taken ecstasy, but pure ecstasy addicts, people with severe mental health problems associated with ecstasy, it's just not on the radar. 15 years I was in the community team in addiction, not a single case of MDMA addiction, or everyone had taken it at some point, and no drug-seeking behaviour with MDMA. So very, very safe, and especially in a clinical setting on screened patients with a doctor and a nurse and a therapist present. Nevertheless, the media conflate clinical MDMA with recreational ecstasy, which is weird, because they don't do that for other things, but they do for this. I'll leave that. So anyway, in their wisdom, the ethics committee wanted us to do lots and lots of physiology, and pulled results over 26 sessions. You get this little transient rise in blood pressure and temperature, comes back down. The green line is drug effects. It's interesting, you can see a little boost when they take a booster at 2 hours. The brown line is SUDS, which are distress or anxiety measure, comes all the way down to 0. They all start a little bit anxious. So that was all fine. No abnormal physiological problems across all those studies. I love this graph because it's so spectacularly boring and says absolutely nothing, which is exactly what you want in a safety and tolerability study. No abnormal bloods pre or post, no abnormal ECGs, no suicides, no low affect. Everyone found it positive and tolerable. So that's kind of the world's most boring graph, but the best outcome you can have. Now, what about come downs? People ask me this. What about come downs? What about giving ecstasy or MDMA to depress people? Well, firstly, let's go back to the epidemiology of ecstasy use. We don't get that many people coming into casualty or drug services with depression induced by ecstasy. That doesn't happen. We certainly don't see it in our clinical use of MDMA. We saw no come downs, not one, across 26 sessions. Indeed, so this is the profile of mood states, POMS. Any scores above 0 are depression. 0 is a kind of euthymia, and anything below is a positively felt mood. So far from depression or come downs, they actually had an afterglow for 7 days after their MDMA experiences. The black line is the first session and the blue line is the second, so they're even happier after the second, until they realise they weren't getting a third. But so again, let's not conflate ecstasy with MDMA. And think about it. Think about how do people take ecstasy? Right, what do? You go to the pub, you drink 3 pints, go to a club at midnight, you take a pill, dance like a nutter, take another pill at 2 a.m, dance like a nutter, take half a pill, go back to someone's house, do a line of cocaine, do another half a pill, drink half a bottle of wine, endless cups of tea, endless spliffs, stay up all night, stay up all day Sunday. If you're lucky on Sunday night, you'll get 2 hours sleep and half a cup of soup. You go into work on Monday and you go, oh man, it's MDMA serotonin depletion. It's a bloody hangover. You've been larging it all weekend. There's so many confounding factors in there for this not to be serotonin depletion. Yet there's this myth about come downs. Now, when they take the MDMA in our clinics, they come in at 9 in the morning, they've had a good night's sleep, they have a chat with the therapist that they've been building up a relationship with for the last 3-4 weeks, take the medicine at 9:30, they're up, they're down by 5 p.m, they've worked really hard, they've bonded really well with the therapist, they haven't taken any other drugs, they've had excellent water balance, they have a decent meal, sleep like a baby, and feel great for a week. Now, we don't have prospective data on different times of the day of taking MDMA. No one's going to pay for that study. I'd love to do that study. I've mentioned that to David Nutt so many times. Like sort of 4 groups, one at 9 a.m., one at 9 p.m., one with cannabis, one with alcohol, one with cocaine, one with dancing, one without. Who's going to pay for that sort of study? And everyone wants to be in the most severe group. So, but the bottom line is let's not conflate clinical MDMA with recreational ecstasy. 5-HTP, there's another one. Don't get me started on that. There's no evidence for that. Australian Sleva. So what are our outcomes? So it took us ages to get our 99.98% pure GMP product because the chemists kept messing it up and had to recrystallize 6 times, and we started with a kilogram of properenol with precursor. We ended up with 109 grams. So during that 18 months, we thought, well, look, we know we can't do a randomized control group because we can't do that. It just has to be a single-arm study. But let's do a treatment as usual study. So we took a similarly matched cohort of people, 14, 12 in Bristol, who were undergoing detox, and we didn't do anything to them, but we used all the same rating scales and entry criteria and screening tools. They all come in on high-dose alcohol on a weekly basis. They all get a detox, come down to 0. We did nothing to them, and then we followed them up at 9 months. And very sadly, but totally not unexpectedly, they pretty much all returned to pre-detox levels of drinking. Now, this cohort did not get nothing. They got the very best that modern medicine gives the alcoholic. They got detox. They had anti-craving drugs. They had MAP groups. They had one-to-one therapy, group therapy, AA. They had rehabs. Some of them had multiple rehabs. But look at that. Now, as an addiction psychiatrist, I have lost count of the times I've put people through 6-month inpatient rehabs and they walk out straight into the pub. Time and time and time again. And it's £40,000-50,000 to do this. It just happens all the time. Treatment for alcoholism are poor. So this isn't a control group, and I get in trouble with the statisticians if I call this a control group. It's a comparison group, and we call it the outcome study. Now there is the MDMA study. All the same entry criteria. Started out on high levels of daily drinking, came down to 0, and that's represented there in terms of units per week. I've overlaid them now, I've changed the axes to say over 14 units a week in order to basically reflect the diagnosis of AUD, 100% in both groups. 75% of the observational study group were drinking over 14 units a week at 9 months, compared to 21% in the MDMA. That's a staggering result, okay? You don't see results like that in psychopharmacology very often at all. Now, there was no control group, there's no placebo, it might not be the MDMA at all, it might be the wonderful therapist. But the point is that I know which group of 12 people in Bristol post-detox I would want to have been in that year. So we have to now repeat this, and we need to do this with an RCT, and we are doing that. So there's a few qualitative statements there. Everybody loved it. I mean, these are really, really hardcore drinkers. Many of them have had multiple detoxes. Most people in community alcohol services have been round and round and round and had multiple detoxes, multiple rehabs. And we had a lot of positive qualitative data. And obviously then the next step is to do a 2B study and against the placebo group, and we've changed the protocol a bit. We're doing this at Awaken Life Sciences, and obviously our plan is to get this drug licensed and approved for the treatment of AUD. Just a little bit about the company and then I'll stop. So at Awaken, there's a whole plethora of psychedelic startups that have come in the last couple of years. We believe we're at the front of the pack. We believe we have the best scientific advisory group on the planet. And we're doing a lot in the way of addiction research with AUD using ketamine, taking Celia's study into phase 3, taking my MDMA studies into 2B and then phase 3. And these studies are already undergoing pornography addiction, sex addiction, gambling addiction, internet gaming addiction. And we're developing new chemical entities. We're working on a new molecule. We've been doing computer-aided design to hit all the right receptors, like MDMA. So we want it to have entactogenic qualities, but we want it to be up and down in 2 hours, which will make it more clinically deliverable. And we're opening clinics. We have 3 clinics, Bristol, London and Oslo. But we are not ketamine infusion clinics. As you mentioned, ketamine was serendipitously discovered to be a rapid-acting antidepressant about 15, 20 years ago, and there's like 600-700 so-called ketamine clinics in the States. They don't do psychotherapy. You just get your infusion of ketamine. Works pretty well as a rapid-acting antidepressant, but it's maintenance therapy. You have to go back and keep having it done and done again. That, for me, is not the sort of medicine I want to do. So when we give ketamine, we give it as an adjunct to psychotherapy. I've heard some people in these ketamine infusion clinics talking about it as a side effect. I remember talking to one guy, and he says to his patients, right, the ketamine's going in now, you're going to feel a bit weird for a couple of hours. Don't worry, it'll soon pass, and then you can go home. Now, that little bit weird that they find an irritating side effect is exactly what we want. We're aiming for this weird. That's not a weird side effect. That is a hugely beneficial, rich psychotherapeutic space, and with psychedelic training you can work in it. So we use it as we do with psilocybin and MDMA. And it also means we're extending the conditions and indications. We're not just doing it for TRD, but anxiety disorders, PTSD eating disorders, etc. Bristol is lovely. Come and visit Bristol. It's the San Francisco of the UK. It's really sick. It's nice. Come and have a look around. We've got clinics, Bristol, London, Oslo. We're opening 15 to 20 clinics in the next 4 to 5 years. We want to be the high street presence for the delivery of psychedelics. These are good. Right, these are the sorts of questions people say. You know, about using psychedelics clinically. You're swapping one dangerous drug for another. That's an absurd thing to say. You know, we use all sorts of drugs in addiction. It's like saying it's not good to swap heroin for methadone. Well, if you're a street heroin user, it's very, very good to swap it for methadone and stabilise that. Yeah, you haven't cured the opiate addiction, but it's a hell of a lot better than scrounging money on the street for street heroin. But anyway, talking of alcohol use disorder, there are very few things you can do that's worse for you than drink a bottle of vodka a day. There's no medical intervention out there that's worse than a bottle of vodka a day. So the idea that 2 or 3 shots of ketamine or MDMA in a clinical setting is swapping one dangerous drug for another that gets you off that vodka is ridiculous. Risk of addiction to psychedelics, very low risk. We see this in animal studies, very low risk. We see this epidemiologically. You don't have drug-seeking behaviour for psychedelics. Nobody breaks into your house to steal your TV to get their next magic mushroom fix. They're just not on the radar for drug services. So very low risk. Lack of research-proven efficacy. Well, the studies are small. The studies are pilot studies. RCTs are on their way. Phase 3 is on its way for psilocybin. Phase 3 is complete for MDMA. But the results are all amazing. They really are all amazing. Our little study, it was amazing. All of them have blown out of the water current best treatments. Sends wrong message regarding drug policy. I'm not even going to get started on drug policy, because if you think I'm ranting now, you wait until I start talking about drug laws, which are unethical, unpoliceable, unscientific, unjust, ridiculous, greatest socio-political folly of the last 100 years, and successive politicians and home secretaries have blood on their hands for killing people unnecessarily and for handing the franchise of drugs to the mafia. It's absurd. So that rant over. Costly and difficult, yes, really costly and difficult. This is a pharma industry nightmare. A drug you take twice and then you're better. Now, I am not a conspiracy theorist. I don't believe that pharma companies want to keep people ill. That's insulting. That's like saying oncologists want people to have cancer. Of course, pharma industries and medics want people to get better, but they just got rubbish treatments. That's why they're not getting better. But for that reason, it's very hard. Who's going to put all that money into these non-patented drugs? Nobody owns cannabis or MDMA or psilocybin or DMT. Erroneous stigmatizing public perception, absolutely terrible. If there's one thing I'll credit the war on drugs for, it has massively miseducated people really, really well, turned intelligent, erudite people into complete numbskulls when it comes to sloppy pharmacology. So, loads of research. In the last 15 years, we need more diversity. You know, you don't need to listen to any more middle-aged, bald men, white men like me. We need more younger people, and we need more diversity in the field. But we've worked with LSD and DMT and ketamine and psilocybin and MDMA. People are calling this a psychedelic renaissance, which is fab, because I came up with that term 15 odd years ago, and now it's like being used everywhere. This is the psychedelic era. This is what's interesting. People talk about the psychedelic 60s. We are way more psychedelic now than we ever were in the 60s. Loads more going on. But people think it's career suicide. This is Michael Mithofer, MDMA pioneer in the States. I was told this at Oxford when I was there doing my postgrad, and they said, Ben, why are you doing this work with these weird hippies? This is career suicide. Why don't you study something nice like SSRIs? It's not career suicide at all. You know, this is not some fringe, like weird thing done by bearded people in California. This is cutting-edge neuropsychiatry. This is cutting-edge biological psychiatry, and it's cutting-edge social and psychotherapeutic society. So if you young people have tutors that say this to you, then you just need to say, open your journals. You know, what have we got? Yale, Oxford, Cardiff, King's, Johns Hopkins, UCL, UCLA, Princeton, where are we? Maudsley, Harvard, Maudsley. They're all doing all these are not fringe institutions, these are cutting-edge neuroscientific institutions. They are all running primary psychedelic research groups now. So it really is where it's at, so get involved. Freud knew this with this wonderful phrase, in the future we may have chemical substances which can act alongside psychotherapy and provide undreamt of possibilities in psychotherapy. So it makes perfect sense, clinically, socially, and economically, to fund and develop psychedelic-assisted psychotherapy. Thank you.